we all know he is the pioneer of get-to-get PCI in this country. Over to Dr. Hassan. Thank you.
Assalamu alaikum and very good afternoon. Thank you, Khalid bhai, for your kind introduction. My today's topic is given by the sky, the difficult retrograde, solving difficult reverse cut in retrograde CTO PCI. I have nothing to disclose, but I would take this privilege to thank, my humble thanks to all the foreign faculties who come such a long way to share their knowledge and experience to treat our patients better, like Dr. Imad Shivan from Italy, and also others who are here, maybe somewhere here. Dr. Ramesh, Dr. Carla, all of them. My history is Mr. X, 54 years old, came to me with effort angina and shortness of breath for 4 years, had an inferior MI, underwent angiogram in another hospital, revealed double vessel disease. Left wing was 70% distal, LAD 80%, osteal, RC 100% distal, recommended for CABG, but he refused. So underwent PCI to left wing coronary artery and LAD on 26/12/2010. At that time, RCCTO tried but failed. Latest investigation this time, few years back, when he came to me, ECG revealed some dynamic changes. There was inferior wall hypokinesia, EF was 40%. Well, we did angiogram after 6 years due to above complaints, which revealed DVT with patterns in left wing coronary artery and LAD. SARC was non-dominant, 80% osteal, RC has got 80% mid, 100% distal before bifurcation. In-play scan showed viable myocardium in RC gateway. So we recommended him for PCI to RCA CTO. So RCA was dominant, 80% mid and 100% distal. CTO has got a blunt stump with a small branch at the stump. Left wing coronary artery stent patent, LAD proximal stent patent, giving collateral to RC by septal branch. SARC non-dominant, 80% osteal. So double puncture, RCA GR5 guide and LAD GL3.5 6-month diagnostic, took bilateral injection to visualize distal vessels. So in summary, it's a RCA CTO, proximal stump blunt with a side branch, no calcification, bending less than 45 degree, CTO length was around 20 millimeter. Previous attempt, yes. So JCTO score was 3. So common question in life, if any problem is to be or not to be, which Shakespeare said. And my problem was antegrade or retrograde. First, I tried antegrade by filtering XTA wire with microcatheter, but failed to puncture the proximal cap. It was hard. Then took Contrast Pro 9 wire, successfully punctured the proximal cap, and went distally. But went to false movement distally, so failed even several attempts to go into the distal RCA true lumen. So decided for retrograde approach. So hooked LAD with XB 3.57 frame guiding catheter, crossed through septal branch to reach RCA TDA with microcatheter and seal. So planned for contemporary reverse cut. Inflated antegrade 2.5 balloon in distal CTO. Tried to aim the balloon with retrograde Gaia second wire. But could not connect the antegrade dissection plane created by the balloon with retrograde Gaia second wire after several attempts. Then took Gaia third wire to Pyra's distal heart cap, aimed the balloon a bit proximally with Gaia third, but again failed to connect. CTO plug was very hard at that point, deflecting Gaia third tip. You can see the Gaia third tip is deflecting just at the connection point. So I took Congress Pro 9 to aim the balloon. I asked the hard plug, but again failed. It went into another plane, could not connect the proximal and retro resection plane. So I pulled the balloon proximally, inflated and tried to make connection in proximal CTO body, but with no result. Then I tried to bring the retrograde Congress Pro 9 wire in the same anti-gate dissection plane and confirm the two wire in the same plane by rotational angiography. At that time, I was not available in my lab. After confirming the two were in the same plane, I took a bigger balloon, 315, to enlarge the anti-gate space and aim it with retrograde wire. Even then, the retrograde wire failed to pass proximally. I was confident that there should be some connection between these two planes because the two wires were so close in rotational angiography in all views. Maybe it was the hardware which is failing to go. So I changed the retrograde wire to slippery filter XTR wire, and after some maneuvering, succeeded to pass in proximal RCA to anti-gate RCA guide catheter. Now trap the retrograde wire with anti-gate 12 balloon in the RCA guide catheter to get support, and took the retrograde microcatheter in the anti-gate RCA guide catheter. Then took out the retrofilter XTR wire. Exchange it with RG3 300 cm wire, pass the wire through the anti-gate RCA guide catheter. And then retrograde RG3 was brought through the anti-gate Y connector. Then anti-gate 2 to 20 balloon passed over this to dilate the RCA lesion. Dilated the lesion, placed 2.75 into 48 stent, confirming its distal position by anti-gate microcatheter injection, retrograde microcatheter injection. Deployed the stent, hole dilated with 315 balloon. Check the septal branch for any perforation. Remember, while you doing retrograde, always check before taking out all the gears that there is any perforation in the collaterals. By anti-gate microcatheter injection, there is no perforation, and this is the final picture. So take home message: planning, technique, hardware, flexibility, and patience are the keyword of success of CTO intervention. Contemporary reverse guard is new technique to increase the chance of success in retrograde approach by specific aiming the anti-gate balloon with Gaia wire and preventing enlargement of the retrograde dissection plane by retrograde wire. 3. If you can't connect the anti-gate and retrograde space, you might have to move to in another different site for reverse guard. Like in this case, when I failed to connect the distal CTO body and moved the balloon to proximal CTO body for reverse guard. 4. Rotational angiography may help determine whether the anti-gate and retrograde wire are in the same plane before reverse guard in the absence of IBUS. As I did not have IBUS at that time, I tried to confirm the two were in the same plane by rotational angiography. 5. Sometimes you need to downgrade your CTO wire to slippery wire to connect anti-gate and retrograde dissection plane. Like in this case, after doing the reverse guard, when I could not connect the two dissection plane by retrograde Congress Pro 9 wire, I downgrade retrograde wire to slippery filter XTR wire and succeeded to connect. So basic principle of CTO is this slide. You have to connect the anti-gate and retrograde gears, the proximal and distal lumen, either by wire acceleration or dissection and re-entry. That's the main funda of crossing CTO. And this is the basic hybrid algorithm we all know. And my last slide, I love to show it while I do CTOs. Keyword for success for CTO. So you're in a long queue for P, and you're the last person in this queue, the interventional cardiologist. To reach your goal, you have to have patience. And you're climbing a steep mountain. To reach the top, you need to have perseverance. So patience and perseverance are the keyword of success of CTO. Thank you.
So we all know the professor is scheduled to leave early, so if you have any questions or queries regarding this presentation, I think you can ask.
I have one question for the professor. I know you are a great speaker.
Would you like to comment on
Thank you, Kasaba, for your nice presentation. And he's a renowned interventionist in our country. My question was, it takes a lot of wire escalation during CTI and a lot of. So my question is, what are the wires you choose for your this retrograde procedure, and what is your strategy? Do you start with anti-gate always, or do you plan to do some cases from retrograde? What is your strategy?
Thank you, Sabina, for your nice question. About trying CTO, definitely I would prefer to do it anti-gate, because anti-gate is easier to do. But if I fail, then only I go for retrograde. Or if there's a previous attempt by in another center, anti-gate once or twice, then I go directly to retrograde. Otherwise, always anti-gate first. And for the retrograde case, to cross the collateral channel, I prefer Sion or filter STR wire, and sometimes 203 for some very screw type of collaterals. And after crossing the collaterals, when I go to the distal end of the CTO, then I try some harder wire like Gaia or Compass Pro 9. It depends by wire escalation. So always I would say my juniors, when you try CTO and treat your retrograde, you first try filter XT wires, XTR wires. If you get some micro channel, you can easily pass. If not, then go for a harder wire like Gaia series, or if it is a very long relation, calcified relation, hard to pyrophone, Compass Pro 912. So gradually you escalate. Thank you, sir.
Thank you very much, Dr. Sir. He is the first intervention of our country, and I must congratulate for that. Basically, my preference with the wire is, of course, if it's a short distance, as a tortuous course, field exchange. Field exchange has a software compared to harder stiff wires. But when it's hard lesion, straight lesion, there's not much of curvature, then you can choose it according to your Gaia 1, 2, 3 Compass Pro. So it depends on the anatomy. You have to choose your wires. Obviously, you did the right thing. I want to ask Sir, how do you choose the retrograde approach? I mean, what criteria you follow when you decide to go for retrograde intervention?
Thank you, Tamil Bhai, for a nice question. For retrograde, especially if anti-gate attempt fail, if we say long CTO like more than 20 millimeter blunt anti-gate stump and good intervention collateral. Intervention collateral is a very important factor for retrograde. Then I'll go for retrograde. And definitely for planning, you have to take some views like areocranial or epicaudal to see the origin of the collaterals. And you have to take very software fast to enter the collateral. Then you change the curve and cross the retrograde. And then when you take your microcatheter and the wire to the distal end of the CTO, then you change the wire into harder wire, like you say Gaia series or Miracle or Compass Pro. But while crossing the collateral, you need a bit of softer wire like Sion, like filler STR, or sometimes 203 wire. Thank you.
Thank you, Dr. Kasar, for your nice presentation. Professor Jamal, would you like to say something?
Thank you, Dr. Kasar, for a brilliant case.
as well as you have started the first case probably 7 or 8 years back, and you have presented that case. That day I was present luckily, and I am very happy with you for doing this innovative work in Bangladesh. And my one thing, I like to add one thing, that for retrograde we shall have a good integrated supply opposite, that is donor vessel. Donor vessel must be healthy, or if the donor vessel diseased, then we shall have to treat the donor vessel, and then we shall go for the total occlusion retrograde approach. Okay.
Yes, I